Mechanism of action of heparin. Mechanism of action of heparin. Heparin interferes with the conversion of fibrinogen to fibrin. Heparin interferes with the conversion of fibrinogen to fibrin. Heparin interferes with the conversion of fibrinogen to fibrin. What is the mechanism of action of warfarin or coumadin? Warfarin and coumadin mechanism of action. Remember that it will decrease the potassium needed to make the factors 2, 7, 9, and 10. It is important to know that the INR required for patient on warfarin to proceed in a surgery has to be between 2 and 3. A value of 1 from 0.8 to 1.2, it's a measure of the PT, external pathway of coagulation. So yes, you can do safely a surgery in a INR up to 3. And INR has to do with extrinsic pathway. So what test are you going to order in a patient with coumadin or warfarin? You're going to order an INR. Why? Because coumadin or warfarin decreases the potassium needed for the factors 2, 7, 9, and 10, which are needed for the extrinsic pathway. Okay, so what is the best test for the patient that is using warfarin? INR or INR PT. PT is measured by the INR. So next, patient on decumarol is probably taking it for patient on decumarol. So you have a patient taking
dicumarol.
Patient taking dicumarol. You have patient taking dicumarol. He's probably taking it for myocardial infarction. Dicumarol is similar to warfarin. And it is taken for myocardial infarction. Next, what INR do you need to proceed with surgery of a patient on warfarin? INR of 2 or 3. The value of 1 is normal. Some say the cutoff we want is 2.5, but INR of 2 to 3. Remember that the 0.8 to 1.2 is a normal INR. What test do you order for an alcoholic patient needing extractions? PT and INR. How do we measure platelet function? Bleeding time. How do we best measure platelet function? Bleeding time. Remember that platelet function, bleeding time is affected by aspirin. Bleeding time affected by aspirin because it affects the platelet function because it has a aspirin has action that is anti uh, anti um, coex, coex, cyclooxygenase A. Aspirin and cyclooxygenase inhibits cyclooxygenase 1 and 2 irreversibly. So aspirin is non-selective and it irreversibly inhibits both forms of cyclooxygenase, but is more selective to cyclooxygenase 1. Normally cyclooxygenase produces prostaglandins, so prostaglandin A, okay, cycloaspirin, prostaglandin A, most of which are pro-inflammatory, and thromboxans, which promote clotting. So how do we measure platelet function? Bleeding time. Remember that bleeding time will be affected by aspirin. What drugs is aspirin contraindicated with? Coumadin and warfarin. Why? Because coumadin and warfarin interfere already with the extrinsic pathway. With coumadin and warfarin, extrinsic pathway to the depletion or the decrease of potassium, which is needed for factors 2, 7, 9, and 10. Extrinsic pathway, coumadin or warfarin. Remember that a patient that is taking what's the name of this drug? Dicumarol. Patient that is taking dicumarol, he has, for myocardial infarction, dicumarol is very similar to warfarin. So anyway, what drug is contraindicated in patients taking ginkgo biloba? What medication is contraindicated with a patient taking ginkgo biloba? Warfarin and coumadin. Prostaglandin inhibitors cause all except increase of gastric mucus. Prostaglandin inhibitors cause all except increase in gastric mucus. Prostaglandin inhibitors will decrease the mucus and increase the acid, leading to stomach ulcers. So when you have a prostaglandin inhibitor for a very long time, you will have a patient with stomach ulcers because there is a decrease in the mucus being produced, and also there is an increase in the acid being produced. What is the purpose of and mechanism of action for sulfonylureas? And sulfonylureas is an increase of insulin production by the beta cells of the pancreas. So beta cells of the pancreas are going to be increasing the release of insulin. So in type 2 diabetics. So it is important that you know that it's in type 2 diabetics that these sulfonylureas are going to be used in or useful in, because the type 1 diabetics do not have beta cells to produce insulin. So if you give sulfonylureas to a type 1 diabetic, you will have not the effect that you need, because type 1 diabetics do not have beta cells to produce insulin in the pancreas. Are contraindicated in patients that are taking ginkgo biloba, warfarin, or coumadin, because they decrease the extrinsic pathway by decreasing the amount of potassium available for factors 2, 5, 7, and 10. Symptoms of hypoglycemia: headache, mental confusion, sweating, tachycardia, tremors, and nervousness. When is elective endo contraindicated? When is selective endo contraindicated? In patients with diabetes and HIV. When is selective endo contraindicated? Diabetic patients and HIV patients. Normal HB hemoglobin A1C. Normal hemoglobin A1C versus problematic. Normal is 2 to 6%, elevated is 7% and above. Normal hemoglobin A1AC. Normal hemoglobin A1C versus problematic. Normal is 2 to 6, elevated is 7% and above. What considerations should you have when treating a diabetic patient? Tell them to eat and take insulin 2 hours before and have a morning appointment. What is fruity keto breath a sign of? Hyperglycemia in a type 1 diabetic. I gotta check on that. I don't know if that's correct. Yes, that is correct. We have another question. When a patient has ketone breath and is confused, why? Because of hyperglycemia. So ketone breath and altered state of consciousness relates to hyperglycemia. Ketone breath, it is seen in patients in diabetes type 1. So, preferred storage medium for biopsy samples, formalin. And we're going to see other questions about formalin, which other way we could be asked. Formalin. So Board Busters has 10% formalin is the substance of choice used for routine biopsy specimen. After removal, the tissue is immediately placed in 10% formalin solution, which is 4% formaldehyde. That is the least. 20 times the volume, at least 20 times the volume of the surgical specimen. The tissue must be totally immersed in the solution, and care is taken to ensure the tissue has not become lodged on the container wall above the level of the formalin. Specimen care. After removal, the tissue should be immediately placed in 10% formalin solution, that is at least 20 times the volume of the surgical specimen. No other solution is acceptable. Talking about a lipoma, AB9, soft tissue tumor derived from adipose tissue. It is smooth or lobulated lipoma, sessile or pedunculated, soft yellowish nodular mass. Vessels are visible over the surface, found in the floor of the mouth, buccal mucosa, and tongue. Yellowish mass covered by normal mucosa. A biopsy specimen will float in the formalin. Lipoma will float in the formalin. Easier to diagnose than other tumors because it is yellowish and soft and smooth. Also will float in the most reliable technique to diagnose soft tissue lesion. Scalpel is the instrument of choice since it cleanly removes tissues without dehydrating them. A cautery or high frequency cutting knife may Formalin at 10% is the fixative of choice. The rationale of surgical removal and biopsy of a large periapical lesion suspected to be of inflammatory origin is that clinical diagnosis can be confirmed microscopically. Biopsy is the only way to distinguish between agranuloma and a cyst. So, formal crestal pulpotomy technique, talking about pulp treatment. This treats primary teeth with carious exposure. Teeth selection is the same as a calcium hydroxide technique and is performed in one appointment. After the coronal pulp is removed or amputated, a cotton pellet moistened with formal cresol is placed in contact with the pulp stumps and remains there for 5 minutes. The pellet is then removed and the pulp chamber dried. A thick paste of ZOE, zinc oxide with eugenol, is placed over the chamber and the tooth is restored. The success of formocresol pulpotomy for a primary tooth depends primarily on the vital root tip. Formocresol is formalin and cresol. It causes surface fixation of the pulpal tissue and odontoblast degeneration. Formocresol is formalin. There is another part where we'll find formalin. Formalin, when you do biopsy, how do you store the specimen before it gets to the oral pathologist? Formalin 10% is the answer. Formalin 10% is the answer. We'll have another place in dental decks about formalin, in which we find that a question that says, in which one of the following cases is an incisional biopsy indicated? In which one of the following cases is an incisional biopsy indicated? A 3 millimeter well encapsulated fibroma, a necrotizing cyalometaplasia of the hard palate, a 2 millimeter papilloma of the left commissure of the lips, or an aneurysmal bone cyst. The answer is necrotizing cyalometaplasia of the hard palate. This one is where an incisional biopsy would be indicated. A biopsy is a procedure performed to remove cells or tissue from the body for examination under a microscope. Biopsies are usually performed to determine whether a tumor is malignant or to determine the cause of an unexplained infection or inflammation. When the entire tumor is removed, it is called excisional biopsy. Excisional. The question is asking in which case an incisional biopsy is indicated. So the first question says, the first option says 3 millimeter well encapsulated fibroma. So if it's well encapsulated, you can excise it. So you don't need to do an incisional biopsy. If only a portion of the tumor is removed, it is called incisional biopsy. An incisional biopsy, also called diagnostic biopsy, is done when lesions are either too large to excise, initially without having established a diagnosis, or of such a nature that excision would be inadvisable. An excisional biopsy is preferred if the size of the lesion is such that it may be removed along with a margin of normal tissue and the wound can be closed primarily. Example, a 1 centimeter exophytic mass, which is a lesion that grows outward from an epithelial surface on the cheek. So, notes, biopsy is a more reliable technique to diagnose soft tissue lesions. Second note, the fixative of choice to preserve biopsy specimens for routine histological examination is 10% buffered formalin. The scalpel is the instrument of choice since it cleanly removes a tissue that does not dehydrate it as cautery or the high-frequency cutting knife may. The rationale for surgical removal and biopsy of a large periapical lesion suspected to be of inflammatory origin is that a clinical diagnosis can be confirmed microscopically. This is the only way to distinguish between a granuloma and a cyst. So the only case in this question in which you will have to do an incisional biopsy will be a necrotizing cyalometaplasia of the hard palate. In all the other cases, you have a 3 millimeter well-encapsulated fibroma, you can do an excision. You have a 2 millimeter papilloma of the left commissure of the lips, 2 millimeters. So in those two, you can do excisions. You can do excisions. So we'll pass to the next. Again, preferred storage medium for biopsy samples, formalin, 10% formalin. A two-step, the next question is a two-step versus a one-step implant. The two-step is the traditional and the one-step is immediate loading. The traditional means placing the implant, letting it heal, and then place the attachment, and then attach the abutment later. Bacteria responsible for implant failure, gram-negative anaerobes. So, what is the distance between an implant platform and an adjacent tooth cemento-enamel junction? 2 to 3 millimeters according to these. Let's double check on that. Distance between the implant platform and adjacent tooth. Distances, okay, so the distance of the implant to the buccal plate should be 1 millimeter. The distance to the lingual plate, 1 millimeter minimum. Maxillary sinus, 1 millimeter. Nasal cavity, 1 millimeter. Incisive canal, avoid midline maxilla. Interimplantar distance, so from implant to implant, 3 millimeters. From the inferior alveolar canal, 2 millimeters. From the mental nerve, 5 millimeters. From the inferior border, 1 millimeter, and adjacent to natural tooth, 1 millimeter, according to what I found. So, okay, so best area to place an implant, anterior mandible or posterior mandible. Worst area to place an implant, posterior maxilla, and this is talking about the quality of the bone. Least important factor in placing an implant the considering bone density, distance to mandibular canal, bone width, and concavity of the mandible. Okay, which is the least important factor in placing an implant? The bone density is important. The distance to the mandibular canal is important. The width of the bone is important, and the concavity of the mandible. The concavity of the mandible is the least important. It is still a consideration, but not that important compared to bone quality and the other anatomy. So the concavity of the mandible is the least important factor in placing an implant. Temperature and time that kills bone during an implant procedure, 47 degrees Celsius for 1 to 5 minutes. That is important to write down. Temperature and time. Temperature and time that kills bone. During implant placement. And the answer is 47 degrees Celsius. For 1 to 5 minutes. So 74 Celsius for 1 to 5 minutes is the temperature and the time that will kill bone during implant placement. Again, 47 degrees Celsius, 1 to 5 minutes, temperature and time that kills the bone during an implant placement. The implant to implant distance, 3 millimeters. Why? Because you need blood to flow in between them to heal them. So implant to implant, 3 millimeters minimum. So yeah, inter-implant distance, 3 millimeters. Implant to tooth distance, implant to tooth, it says here 1.5 millimeters, but I have another source that says 1 millimeter. So either 1.5 or 1 millimeter, and I got actually all this information from Mosby. So 1 millimeter. Implant to nerve, minimum distance. Implant to nerve, inferior alveolar canal, 2 millimeters. But if it's the mental nerve, it should be 5 millimeters. Implant to nerve, minimum distance, 2 millimeters. If an implant has a 4 millimeter diameter, what is the minimum width of the ridge needed? 6. Why? Because it needs 1 millimeter on the lingual plate and 1 millimeter in the buccal plate. Distance between implant platform and adjacent tooth, cement-to-enamel junction, 2 to 3 millimeters. Distance between implant platform and adjacent tooth, cement-to-enamel junction, 2 to 3 millimeters. Next, how do gingival fibers orient themselves next to an implant? Parallel to the cuff, with cuff, circular, creates long junctional epithelium. How do gingival fibers orient themselves next to an implant? Parallel with cuff, it creates long junctional epithelium. The implant platform and adjacent tooth, cement-to-enamel junction, 2 to 3 millimeters. How do gingival fibers orient themselves next to an implant? They go parallel with the cuff, circular, and creates long junctional epithelium. Parallel with the cuff. Contraindications for implants: uncontrolled diabetes, cleft palate, bruxism. Age is not a contraindication. Implants can still be successful in older people. Preferred occlusal scheme for implant crown: metal occlusal. Metal occlusal. Purpose of a hex screw: anti-rotation. Hex screw. Hex screw on an implant. Hex screw. So, purpose of the external hex: stabilization of the abutment. Purpose of the external hex: stabilization of the abutment. Okay, the external hex: stabilization of the abutment, and it also obviously helps it to reduce the rotation, the chance of that it rotates. So, purpose of the hex screw and the rotation. When do you use screw retained implants over cement? When you don't have space occlusally. When do you use screw retained implants over cement? When you don't have space occlusally. When to assess osseointegration of the implant? Before placement of the abutment. Torque it before restoration. Torque it before restoration. Purpose of the external hex: stabilization of the abutment. Purpose of the surgical stent: to align implants properly in its angulation, location, and thickness, not to number the implants. Okay, so that is the purpose of the surgical stent: aligning the implants properly, its angulation, location, and thickness. An implant is angled facially so that the screw might be visible. Okay, an implant is angled facially so that the screw may be visible. What do? You can use an angled abutment in cement. An implant is angled facially so that the screw may be visible. What do? Use an angled abutment in cement. What are the advantages of the open tray technique? What are the advantages of the open tray technique? Pickup impression, open tray technique. It reduces the open tray technique. The advantages of the open tray technique is that you can do a pickup impression. This will reduce effect of implant angulation. it won't have to put coping back into the impression. It will be more accurate. The impression material will not be deformed. So the open tray technique is specifically indicated when the implants are not sufficiently parallel to allow an impression to be withdrawn from multiple impression copings. The closed tray impression technique is utilized if the implants are parallel to each other. So if the implants are not parallel to each other, we can use, like in this case, we can use a we can do an open tray technique. Okay. Implant success is determined by its mobility, whether the implant is properly osseointegrated. Implant success is determined by mobility, whether implant is properly osseointegrated. What causes the most implant failures? Overheating during surgery, so surgical error. What causes the most implant failure? Overheating during surgery, surgical error. What is the worst type of force for an implant? Horizontal. Worst type of force for an implant? Horizontal. The force that is worst for implants is the horizontal force. What is the ideal location for an implant abutment interface? At the height of an alveolar bone. Ideal location for the implant abutment interface? Height of alveolar bone. Next, all are symptoms of occlusal trauma to implants, except all of the following symptoms are going to be are symptoms of occlusal trauma to the implant. Okay, you will have breakage of abutment screw, loosening of the implant, pain, or gingivitis. So all of them are true except gingivitis. All of the symptoms of occlusal trauma to implants are pain, loosening of the implant, breakage of abutment screw. All of them except gingivitis. Next, criteria for implant success: immobility, absence of peri-implant radiolucency, adequate attached gingiva, average bone loss of up to 0.2 millimeters per year. Average bone loss of up to 0.2 millimeters per year. So that's the criteria of an implant success. Up to 0.2 millimeters of bone loss per year, adequate attached gingiva, or an absence of peri-implant radiolucency, and immobility. What are implants most commonly made out of, and why? Titanium, because forms a titanium oxide layer that helps with osseointegration. When only 2 out of 3 of your implants sit, what do? Section and re-index. When only 2 out of your 3 of your implants sit, what do? Section and re-index. So in placing an implant, you want low speed, high torque. Placing an implant, you want low speed and high torque. What is the purpose of saline irrigation in implant surgery? Prevent bone from overheating. 10-year success rate of implants, 90 to 95%. When do you not immediately load an implant? When there is bone grafting with guided tissue regeneration. When do you not immediately load an implant? Bone grafting with guided tissue regeneration. Where do you put rests for an implant supported removable partial denture? Where do you put rests for an implant supported removable partial denture? You don't. Appropriate age for implants, wait until patient is at least 18. How to clean an implant, use a plastic or gold instrument, no steel, no stainless steel. How do the connective tissue and epithelium connect to an implant? Epithelium attaches with hemidesmosomes, connective tissue does not connect the same. How many implants for a maxillary complete denture?
How many implants for a maxillary complete denture? How many implants for a mandibular complete denture? 2. Proper order of extractions for upper posterior molars.
Proper order of extractions for upper posterior molars. The third first, then the second, then the first molar. This is done like that to prevent tuberosity fracture. Maxillary first, and the maxillary first and most posterior first. Maxillary first before the lowers, so you don't so you extract maxillary first. So any particles falling, so if you do it backwards, if you do extract mandibular first and then uppers, you can have residues or debris falling from the uppers into the lowers, so that's why you do uppers first. Where is the maxillary third molar most likely to be displaced? Into the infratemporal fossa. Most common impacted tooth besides the third molars, maxillary canine. Tooth least likely to be congenitally missing, the canines. Tooth least likely to be congenitally missing, canines. Easiest and hardest type of impaction to remove. Distal angular are harder to remove. Mylohyoid surgery most likely to damage which nerve? The lingual nerve. Why? Remember that the lingual nerve damage okay, again the question says mylohyoid surgery most likely to damage which nerve? Mylohyoid surgery mylohyoid surgery most likely to damage which nerve? The lingual. Why? Because the mylohyoid goes from the hyoid bone inside in the inside of the mandible, very close to, attaches very close to the median fibrous raphe and adjacent to the hyoid body and origins in the mylohyoid line of the mandible. Okay, and the mylohyoid line of the mandible right here. It's very close to where the lingual nerve will be. Okay. only reason to extract a third molar in an older compromised patient would be due to a pathology.